introduce our moderator for the next session, who will treat everybody on here as a panel, including people who may be presenting late in the week, because again, the public is Black Bioethics, then SI, AI, AI, and then we go into policy. And we want to make sure that we ask the kinds of questions now, so the policy people like Dr. Isom and Shelley Tremblay, and that they will have all that they need to kind of answer questions, because we need to know what we need to do to make sure this stuff becomes policy, the kind of stuff that we're talking about here today. But before we do this, I want to I want us to, let me see, share sound. I want us to listen to a little TED talk that's germane to our present conversation. Um, can you see that? Okay.
The medical profession may be doing harm to patients and communities. Many years ago, as a first-year medical student, I took an oath, like thousands of physicians before me and thousands of physicians after me, that I would first do no harm to the patients and the communities that I serve. And since then, I have committed my career for taking care of patients in underserved communities, just like this one on the Near East Side of Columbus, Ohio. But over time, I've seen that the medical profession has broken that social contract with the communities that we serve because of racism and placism. Now, this is going to be best illustrated if I walk you through the lives of two of my dear friends. So first, let me tell you who they are. Many years ago, as a young, aspiring physician, new to practice, I started my career off in Connecticut, where I had the good fortune of meeting two wonderful women who would become lifelong friends and honestly like family. And it is through their lenses that I will walk you through the impact of racism and placism in medicine. So first, I want you to meet Wendy. Wendy's a Black woman. I met Wendy as a middle-aged mother, hardworking woman, working so hard to provide for her kids. Through my relationship with Wendy, I've learned so much about tenacity, grit, and honesty. I also want you to meet Sarah. Sarah's a white woman. I also met her as a middle-aged woman, a mother, hardworking, did so much to provide for her family as well. And through my friendship with Sarah, I've learned so much about allyship and loyalty. Now, when I met Wendy and Sarah, they lived about 6 miles apart in central Connecticut. Sarah in the wealthier suburbs outside of West Hartford, and Wendy in the inner city outside of East Hartford. Although they only lived 6 miles apart, their potential interactions with the healthcare system could not have been any more different because of racism and placism. So let's talk about what those mean and what those look like in medicine. Racism in medicine means that Wendy, as a Black woman, would be much less likely to have positive interactions with the healthcare system, much less likely to be taken seriously by doctors, and much less likely to have state-of-the-art healthcare wherever she lived. Because in medical school, we are taught that Black patients have a higher threshold for pain. If Wendy came to my office presenting with pain, as a Black woman, she would be significantly less likely to have that pain addressed. Similarly, if Wendy, as a Black woman, presented to the emergency department with crushing chest pain, she would be 50% less likely to receive any life-saving intervention for a heart attack. Now, in medicine and in nursing, we're often taught to discount and discredit the symptoms of Black women. So if Wendy, as a Black woman, went through her pregnancy, she would be 3 to 4 times as likely to die in that pregnancy or in the childbirth than Sarah would as a white woman. Similarly, if Wendy gave birth to a baby, she would be twice as likely to bury her baby before the age of 1 than Sarah would as a white woman. And if Wendy gave birth to a Black baby and that baby was taken care of by a white physician, that baby would have an increased risk of dying in that first year. Racism in medicine also means that although Wendy, as a Black woman, would be much less likely to be diagnosed with breast cancer or colon cancer, if she were diagnosed, she would be diagnosed with much more advanced disease, later stage disease, and have a 50% higher mortality than Sarah as a white woman. And so it's not really the phenotype of race, it's the structures of racism that would lead Wendy to toxic accumulation of stress that would lead her to earlier heart disease than Sarah.
What happens in the first 7 to 10 days after you quit drinking? Hi there, I'm James Swanwick.
So racism is taking its toll in medicine. Now, the other issue is placism. And by placism, I mean the ignorance of a person's place, where they live, their zip code, on their health. We know that 80% of a person's health status is determined by social determinants of health, not their interaction with me as their doctor. The conditions where they live, work, play, school, housing, economic security, jobs, safety, violence. But chances are your doctor has looked at you and made a decision on how they will care for you based on your race, but they have never paid attention to your place or your zip code. So this shows up in significant health disparities in life expectancy. If you look at the state of Ohio, in green, you'll see the wealthier parts of the state. People have a life expectancy into their late 80s, almost into their 90s. Not too far from some of these same places in red, you see that people have a life expectancy in their 60s. So there can be a 29-year difference in your life expectancy based on where you live. Now, if we zoom in on where I am right now in Central Ohio, the life expectancy challenges are the same. You can see places that are not that far away have over 27 years of a difference in life expectancy between the poorer and the wealthier zip codes. Where I'm standing right now on the Near East side of Columbus, Ohio, a mile away in a wealthier suburb of Bexley, people are expected to live 18 years longer than the people in the community that I'm standing in. Chances are, no matter where you are in the United States, these same health disparities exist. These same problems based on your place exist. So back to Wendy and Sarah. When I met Wendy and Sarah, they lived about 6 miles apart. But that meant that Sarah was expected to live to the age of 84, and Wendy to the age of 68, a 16-year difference based on 6 miles. So you may wonder, what if we just moved Wendy over to where Sarah lived? Would that change? Unfortunately, because racism would follow her, Wendy's life expectancy would not change. It would be as if Wendy lived in the same place for her whole life. And that is because racism is the father of placism. Placism is the derivative of racism. Structural housing discrimination, redlining, and many other structural factors have led to the reasons why people in certain communities have lower life expectancies. So how then can I have lifelong friendships with Wendy and Sarah? I want us all to live and have our relationships until we're in our 80s. This is where I believe that we can make a difference through changes in education and leveraging technology. So with education, we need to dismantle and deconstruct racist, oppressive, prejudicial, biased education that we provide to medical students, nursing students, and other health profession students. The same mythology and stereotypes that were used to justify slavery are still used in medicine today. We need to dismantle and deconstruct that sort of education and instead replace it with anti-racist, anti-oppressive, scientifically focused, stereotype-free, and informed care that allows us to give equitable care to our patients. But what do we do then if we change the educational system? We know educational reform takes a long time. What do we do about the thousands and thousands of physicians like me who are not going back to school anytime soon, but they have been unfortunately indoctrinated with these awful stereotypes and beliefs about their patients? This is where I believe the second solution can help us. Technology can help us be anti-racist and anti-placist. So what might this look like? Chances are if you go to a doctor's office, they are using an electronic medical record where they're collecting so much information about you. And I believe that we can use clinical decision algorithms that will allow us to be anti-racist and anti-placist at the point of taking care of you. Because most doctors have looked at your race, but they have not asked about your place. So what would this look like in real life? Let's say a patient, Molly, came to my office. And in the course of care, which is customary, my medical assistant, before I see her, would collect her height, her weight, her blood pressure, and ask her about her pain on a scale of 0 to 10, with 0 being little pain and 10 being her worst pain. What if Molly said she had a 7 out of 10 pain, but as often happens to Black patients, I didn't pay attention to it? What if the technology could call that pain to my attention and stop me before I could do anything else in that electronic health record and say, studies tell us that Black women are much less likely to have their pain addressed. Are you sure you do not want to address Molly's pain? I could say, yes, I'm sure. I do not want to address her pain. I want to be racist. or I could go back and I could do something different. Similarly, if I was not managing her high blood pressure with the top of the line agents, we know that Black patients often get the third or the fourth line agent for their hypertension. What if the technology stopped me here too and forced me to be anti-racist and reminded me that African American patients are much less likely to get prescribed first line agents? Are you sure you do not want to change Molly's medication? I could say, yes, I'm sure. I want to continue to be racist, or I could go back and do something different. Same thing could apply to colon cancer screening if I did not screen my patient, as often happens to Black patients. The system could ask me, it could force that into my consciousness, it could force me to do no harm. What can we do about placism? So chances are we have not paid attention to your zip code, nor would we know what to do with it if we saw it. So what if we use community mapping tools and a lot of the geospatial imaging that we have to tell us about social determinants of health, not only your risk based on your zip code, but also what to do about it? What if the technology called out my patient's zip code and told me that she lived in this zip code where she's likely to die early from heart disease? Will you discuss heart health and disease prevention with your patient? I could say no, I want to continue to be placist, or I could go back and do something different. I believe we can do this. I believe we can turn the tide and renew that contract with medicine. But it's going to take patients, institutions, and doctors to all play their part. So patients, be empowered to ask more from your doctors. You have a right to full health. Ask us to address your pain. Ask us what screenings you should be having based on your age or your gender. Ask us if we were really on the first-line medications for your condition. But institutions, you also have a role. You need to retrain your doctors, your nurses, your health professionals. Deconstruct and reconstruct that educational model that you have. Teach your physicians, your nurses, your health professionals to see patients as whole people. Teach them to be humble, culturally empathetic, and to see their patients as their own. And finally, doctors, my peers, my colleagues, we took an oath. We promised our patients and our society that we would take care of them, that we would do no harm. Honor your oath and give patients the love and the care that they need. And together, we can give life, love, hope, and healing to the communities that we serve. And together, we can do no harm. Thank you.
Thank you very much for sitting through that. I want to introduce to you now. When I first saw that talk, I thought it was very, very clearly articulated and to the point. So I want us to now generate questions, and I will now be silent as I introduce to you my dear brother T.S. Harvey, who is associate professor, excuse me, for medical and linguistic anthropology, global public health, environmental protection, and medical communications and medical communication risk and misinformation. I was thinking he fits in very nicely in this spot, but he also would have fit in very nicely in tomorrow's spot in talking about AI and the ethics there, because so much of the AI problems has to do with linguistics and language, and as I think Dr. Ray pointed out, the implicit biases that comes up with this. And so therefore, we present to you now Dr. T.S. Harvey, and he's going to lead. I'm going to sit back, and unless I'll probably be part of the panel, so we could ask questions. Thank you very much, Dr. Harvey. Take over.
Thank you, Dr. Hodge. Thank you, everyone. Thank you, Tuskegee University. It's an honor to be a moderator and to have sat and listened to these excellent presentations. Much appreciated. So my role here is to try to facilitate. That's not an easy task, given the depth and breadth of the topics covered. But what I'd like to do is to kind of give an overview of my role here. So as Dr. Hodge mentioned, I'm a professor of medical and linguistic anthropology. I look at global public health in addition to infectious disease. And currently my colleague and I, Dr. Ted Fisher, we have a grant, a 3-year grant from the Robert Wood Johnson Foundation. And we are building a collaboration with Tuskegee and Dr. Hodge. Our work focuses on the cultural context of health. And our collaboration seeks to support the effort to move towards a Tuskegee Report. So I say that as a frame. I have a few slides to kind of set up our discussion of the Belmont report and kind of next steps. And after that, we will open it up to questions. So I'm gonna share my screen here. All right, can everyone see that? Nod your head if you can. Hopefully you can. All right, so we start with the Belmont report. We know that you know, this is sort of the cornerstone, or has been the cornerstone of discussions about ethics around not just practice, but around research. And we're going to get to a brief discussion of sort of what that distinction between practice, healthcare, the provision of healthcare, and research means. But we want to guide a conversation beyond Belmont. So this, just for context, 1978, what's important here as we think about what it would take to produce a Tuskegee report, it helps to think about sort of the framing of this one. So this is 1978. It came out that the idea was the protection of human subjects of biomedical and behavioral research. I want to sort of put a pin in very briefly the language here to think about protectionism and to think about what it means to consider the people with whom we work as human subjects. It took nearly 4 years to create and was based on directives that came out of what was then called the Secretary of Health, Education, and Welfare, which now would be Health and Human Services. There were 11 members tasked with 4 things that were, 1, identifying boundaries between research and practice. As I said, you could read practice here as the provision of healthcare, and research is research. 2, determining the role of risk-benefit analysis in human subjects research. 3, they were tasked with outlining appropriate guidelines for subject selections. And 4, providing criteria for what constitutes informed consent. So that was sort of the task. That was what they were to do. What I'd like to propose is that the current task for Tuskegee Report would include, but not be limited to, critically examining and redefining, 1, the appropriate lines between practice and research, that is to say, the provision of some sort of medical intervention and research, to think through those lines and where they are today. 2, to address and redress the harms unique and everyday done to both individuals and communities. And this has come out in a number of the presentations, right? So this is not just historical, this is not just unique, this is everyday and contemporary. 3, another thing that could be done here is to revise and update guidelines for transparency, not just transparency in terms of research, but also transparency in terms of practice. 4, problematize the historical role of protectionism. Notice the term protection in the title, right? And the relationship of institutions to individuals and communities that it presupposes. So what does this idea of protection insert into that relationship? And how does that relationship relate to the history of failures to protect? Of course, connected to that is this paternalistic discourse of protectionism. So we would also have to consider that. The 5th piece is to decompartmentalize the artificial pairings of informed consent, risk-benefit analysis, and subject selection to specific principles. And I'll talk about that, in favor of the equal application of all of these to the 3 principles. So one observation that I want to make here is, it's not unique to me, but the Belmont report's 3 ethical principles, which is what we've been talking about in substance, is the respect of persons, beneficence, and justice, right? And I put plural there, even though that doesn't work in English, because what I'm trying to articulate there is that there's more than one. Are hindered, the argument that I'd like to put forward is that these 3 principles are hindered by an underlying reductionist framework. That framework that's operating in the background of the Belmont report, I will argue, assigns and defines the relationships of researchers to subjects based on deductive dichotomies. So more specifically, that is, Belmont's 3 principles, respect of persons, beneficence, and justice, right, are neatly matched to a single aspect of the research process, where respect of persons is neatly matched to and applied to informed consent. Beneficence is neatly matched to and applied to risk-benefit analysis. And justice neatly matches and is applied to subject selection. The argument is that that is fundamentally flawed. The Tuskegee Report would need to avoid the pitfalls of these kind of Cartesian reductionisms and insist that research processes of informed consent, risk-benefit analysis, and subject selection be applied equally to the principles of respective persons, beneficence, and justice, and not compartmentalized. So that is my introduction, but the idea here is to think about the role of Black bioethics in decolonizing, if you will, this Belmont report, and to think about, despite the fact that these are squares, the interrelationship between, for example, autonomy, beneficence, justice, and non-malfeasance. So with that very winded introduction, I'd like to sort of begin a conversation about sort of mediating the conversation between our experts. Dr. Hodge.
You could ask questions, put out the questions in the chat room or otherwise.
Yeah, so just to start this off, I guess what I'm wondering is if we can talk a little bit about, from your particular perspective, the way in which a Tuskegee report would garner the authority needed in order to sort of push back. So in the case of Belmont, it was an easy task. They had authority because they came out of the institutions of government, but part of its pitfall is precisely that. So if we're thinking about and reimagining something otherwise, how would, through your work, would you begin to consider how that could be framed? And that goes to any of the panelists.
But Lachlan's hand is raised, so Lachlan first, and then Keisha Ray.
So, Dr. Harvey, thanks for that overview. And I love, as my brother David knows, the idea of thinking deeply about how a Tuskegee report might be different from the Belmont report, not just because we're so many years later and what we've learned from that. And I'm going to suggest, my brother David knows, that we think even more radically than some of the things he suggested. I personally think the fundamental shortcoming of the Belmont report, and really, really thoughtful people who were brought together and worked hard for years, was that it was seeing all of the issues through the eyes of the researchers, the doctors, and others, who then needed to have respect for the people they were studying, who needed to be beneficent to the people who would receive that beneficence, and who needed to be just in their selection of who they were doing studies of. And what I'd like to at least have us think through for Tuskegee Report is think about everything through the opposite direction, through the eyes of the people for whom all of health and healthcare is supposed to be designed to benefit. So what I've said the last couple of years is, if we imagine it was 1930, and rather than thinking about failures of informed consent, the researchers should have respected the person who got informed consent, or they should have thought about the harms that they were doing. If instead we looked through the eyes of Mr. Charles Pollard, or through the eyes of Mr. Freddie Lee Tyson, and people might go into the community of scientists and say, you know, we found in your community possible issues about what we call syphilis, you know, but they've been living in the community with the problems that syphilis caused, and then ask them, the men and the families in the community, what would you like to do about this, and how can we work together? We'd have very different questions than, are they signing a consent form for me, or what am I doing? And my guess is that if you'd asked the men and their families in 1930, once you'd help them understand what syphilis was and what it was doing in their community, that not one would have thought, oh, let's follow people untreated. Not one would have thought, oh, let's get details about what this disease does to us. That all of them would have said, let's figure out with our wives, our children, and others how we eradicate syphilis from this, and then would have told the people from the U.S. Public Health Service how they might have helped. So I would like to be seeing the whole field of Black bioethics, building from Dr. Ray's work and others, for us to stop talking about these communities and about the harms or benefits for them, or about how we respect them, but instead look at everything through their eyes and ask them whether or how they want professionals or others to be doing things serving in service of them and their goals. That would be turning everything upside down, or actually, I think, right side up. So I'm looking at Mayor Haygood. Mayor Haygood, if you were invited to say, for the people of Macon County and their health, what would the people of Macon County most want Black bioethics to be mobilizing people to do? And then you and the people of Macon County would be telling Dr. Hodge and me what the field of Black bioethics might be offering you and your fellow citizens.
I would like to respond to that quickly, because what T.S. Harvey and Ted Fisher and the other crew from Vanderbilt, what they've done is created the support so we could actually have those kind of community think tanks and groups. That's part of the process. So we're looking at about a 3-year timeline to not just to actually create these kind of venues in different communities, not just in Macon County. So if we get, for example, Keisha Ray to be a part of this conversation and what she's doing, to have a community group, informed community group in Houston, and have that kind of conversation, to ask those kind of questions. And we could do it via YouTube, or sit down in more personal spaces, because we realize that many of the people we're talking about don't have access to YouTube. They still have access to walk down to church, right? So you go to the churches and so on. So these particular community spaces and libraries, I think, will be a great access point as a start. That's a start to the answer. Mayor Haygood, would you like to add anything to that?
No, simply, I think it's a great opportunity to get the input from the citizens themselves about what is needed, what the challenges they realize or we realize in our community, and what the barriers are. Like you talked about, the impact of sidewalks and other factors that may present some challenges to people we don't necessarily think of. So when Dr. Farrow mentions getting that input, I think it'll be critical to have those kind of interactions directly with citizens and hear from them in terms of what we see could be addressed, from the effort that's going on with bioethics. And then what concerns we have of what's been presented to them, some things we may hear from them. So I think it's an excellent suggestion.
Thank you so much. I want to add, wait.
If I can just add,
Okay.
Add one thing. An organization I introduced Dr. Hodge to, it's done this all over the world, is Partners in Health, Paul Farmer's organization. And when he started in Haiti, he went to the villages and basically said, how can I help? And in Rwanda, how can I help? And then not only does he find that he thought he was going to go and help with AIDS, but first they said, we're hungry, we need food. And then when they had food, then they wanted to talk about the AIDS medication. So first thing first, in that process, when he helped them, or actually they helped the people who told them how to help, the relationship now was stronger than would have been if they'd been bringing in AIDS drugs. And then what they also found was there were all kinds of people and talents in those villages, including girls who hardly knew how to read, who could be taught songs to say red pill in the morning, blue pill at night, other things. And in the community itself, they found all kinds of strengths that could solve a lot of the problems. But the community said, except we don't have the medication. We don't have these things. Here's some things we need from outside.
Thank you, Lockton. Relationships is the beginning of relationship is the absolute beginning of trustworthiness. And I think that's exactly what you just said, Lachlan, that with the Paul Farmer group, what he did was first worked at his trustworthiness. And then when he had that going, then they could start trusting. Very good, and thank you. And so Keisha, Ray, you have something to offer, please.
Yeah, I just wanted to add that, to give a short presentation, so couldn't elaborate, but a part of the work of Black bioethics and the part that I feel like I add to the conversation is thinking about stories as this representation of data, but then also as this connection between the communities that we serve, right? Having someone's story is about letting to shine the light on the humanity of it, right? Like Dr. Holmes talked about the humanity, that our humanity. And so when I think about what this document could be, that you want this document, you want this to be a living document, you want it to be a trustworthy document. One way to do that is also thinking about not only just letting communities tell us what they need, but then also showing that we have a competency, right, as researchers that can go beyond academia, that can go beyond these kinds of settings. And the philosopher in me is first about language choice, right? Even things like when we do these conversations with students, we say subjects. That's an outdated word, right? We don't use the word subjects, we use the word participants, right? We don't say that this is just you are subject to this against our will, but it gives you sort of an ownership of the research that you are a part of when we call you a participant and not a subject. So even little things like that can sort of transform the community's role in these kinds of documents, and it can sort of show that this is not really about you. This is not us telling you what you need. This isn't about us proselytizing to you, but saying we want to invite you in, tell us how we can use our talents and your experience of being actually in the community and mesh those two things together. And that is why when we're talking about this work, it's so important to not just have the data and our slides and things, but to say, here's a story of how this really affects someone, because it shows people the sort of long reaching effects of poor health. And I think drawing those connections will be important for a document like this to show the extent of how poor health can really badly influence the trajectory of your life. But even word language, I would say, is something really careful to think about.
Yes, absolutely. I think those are all very important points. And just to interject as we move the conversation is to also think about sort of indigenous responses to bioethics and community approaches, right? To thinking about where knowledge is produced, thinking about who can be authority on this, and sort of decentering that relationship, which is, as Dr. Ray pointed out, it's kind of institutional subject, right? To shift that, to decentralize that. We have a question here in the chat that I'd like to send out. It's from Dr. Achebe, who wonders, talks about the critical role of education and wonders how we can ensure that historical Black and Brown colleges have pertinent programs, for example, degree and certification for community dwellers whose jobs are being displaced. As we talk about in the context of AI specifically.
Okay, I was thinking when I looked at that question, I was thinking that question would be probably more strongly addressed in tomorrow's session.
I see.
But then when I rethought the question, and I think Dr. Prakash is on here. Yeah, he's on here. I don't know if he's available, but when I thought about it, this came to mind. First of all, actually, you know what? Let Lachlan, where is he? Let Lachlan answer this one. When Lachlan was introducing me to a thing, I can never pronounce it right. Telemedicine. And so I'm gonna start off, Lachlan, and you can take it from there. There's a town in Alabama. I don't know where it is. I just saw it in a thing about 5-10 years ago about this mayor who saw what was coming down the pike. And what he did was this mayor started retraining, set up a community college with classes and sessions to retrain for what was coming down, so that people, as they lost their jobs, they would be ready for the next version of what's going to happen, right? It was very powerful. So he's actually started building grids for water and electricity where there was nothing there, so that then he could invite Amazon later on and different kinds of businesses to occupy those spaces and to provide the workers based upon it. So that was really genius. So now those people who were just basically working for minimum wage, they were retrained. So now I'm thinking in terms of the telemedicine and so on. What happens if we could retrain persons based upon this question? Retrain persons in computer technology, computer science, um, um, app, app application preparations, so that they could help with telemedicine and help people to understand how it works and probably go from home to home to understand it, so if you can't come to your doctor, then you can meet with your doctor at home. So Lachlan, can you tell give that story, not sorry, that can you tell a narrative about the telemedicine that you were telling me about?
What I'm going to, I guess the way I'll tell the story is also channeling something that our sister Lily Head has said a number of times in conversations, which is one of the things that saddens her is that in Macon County, there is not currently a hospital or health facility for the people of Macon County. There used to be, right? Andrews Hospital. And so if I'm imagining the future, including with AI and other things like that, then if I'm someone, say a pregnant woman in Macon County, and I'm not sure whether I'm okay, do I have to go all the way to Montgomery just to like find that out? And the answer is no, you don't need to. 10 years ago, and this is what I think my brother Dave wants to talk. 10 years ago, with a colleague, it was the 100th anniversary of the Albert Schweitzer Hospital in Africa. And one of the things we demonstrated, Milton Chen with an company called BC. This is 10 years ago in rural Africa. There was a pregnant woman, a couple of hours by boat upstream from the Albert Schweitzer Hospital, pregnant woman, in a village that had no electricity and no cell phone signal, zero. And what Milton did 10 years ago was he borrowed from Intelsat a battery powered satellite phone and sent a medical student with a little bit of training 2 hours upriver, telling the medical student, where do you put the microphone on this pregnant woman in the village in the middle of nowhere abdomen? And that image, the ultrasound, the baby's ultrasound, then via satellite was seen at the Albert Schweitzer Hospital and also at my hospital at Harvard in Boston. And in real time, that woman in that village could have expert doctors anywhere in the world look and see what's going on and find out that her baby was okay, or could, which it was, or could have said, oh, there's something that needs to be done, maybe locally, or might even have said, oh, medical students should bring her back to the hospital. So in the future, in Macon County, but anywhere on this planet, with AI and digital communications and other things, if we start from the human being, like a pregnant woman in the middle of nowhere in Africa, but it could be an older person with man with chest pain, this is a heart attack, and you can have at their place with simple equipment, somebody who transmits the information to an expert somewhere who can then either give advice or say, yes, you do need to make the trip if we have transportation. And then I think what we need for this mostly, and again, I'm thinking of the people of Macon County, just because we're talking about this and we have Mayor Haygood, but it's the same thing if it was rural Haiti or rural Oklahoma or Native American community in the Southwest. It's the same principle. What you really need is human beings who are trusted by the woman or the older man, the Native American elder, the human being who can be taught how to put the microphone and the equipment there, but it's the relationship. And that can give jobs and employment to people in all of those communities, because you need a human link between the person in the community with a health concern, and then the technology connects them to University of Alabama, Birmingham, or other places. but it always comes down to human connection. And I think if we started from the perspective of human beings and what they might need anywhere in the world, understood, so how can our technology, how do we just make it work so that we learn everything we need about in the way that works best for them, and then have local people in their community who have the cultural ability or knowledge they're part of the community be the human connection. I think if we think about all the AI and other things in those ways, we could transform the way we do health and healthcare, where every human being, regardless of skin color, language, ethnicity, indigenous status, is valued. And I will also say that this isn't charity, oh, the people in Boston, whatever, being nice to other people. I will say the doctors I knew who were part of this at my Harvard hospital loved feeling humanly connected to this woman in a rural village whose language they didn't even speak. The other human beings with my color skin loved that human relationship and being able to be helped.
Yeah, I think this is a wonderful sort of intersection of Dr. Holmes's presentation and his work and Dr. Carr, because essentially Dr. Carr is going to sort of has talked about the context in which these inequalities exist, right? And Dr. Holmes reminds us, right, of that fundamental sort of aspect of deservingness that's built into what it means to be human in the world. Because I think the technology in and of itself, right, is not the answer, because in the hands of structural inequality, we don't necessarily move beyond. So I think if Dr. Carr and Dr. Holmes would contribute to this, I think it would be wonderful. Which would like to go first?
Yeah. Dr. Carr, please go first.
Would get put on the spot. Thank you so much. Repeat the question one more time.
So the idea is, right, as Dr. Farrell points out, right, we have wonderful technologies and we have people who are inclined to help, right? But what we know from your presentation is that the context itself, the context of health, right, matters. So as we're thinking about the intersection between the existence of technology, right, and access, which Dr. Hodge talks about, right, how is it that what you've presented and the work that you're working on can help us to understand what needs to be in place in order for us to be inclined to use the technology in a way that could remediate some of these problems? What do we need to think about in terms of the context that needs to change?
Right. So from my presentation, what I've researched and worked on is, and I'm coming from an agricultural standpoint, especially with technological fixes when we talk about global, food security and global food sovereignty and all of those things. So for me, looking at it, it's coming from a sustainability standpoint and making sure that the technologies that are there are not detrimental or depletion to that environment, which goes back into climate change, which goes back into how that heat signature, that heat footprint of what it means to grow your own food. And as we become we're supposed to become more decentralized with the global corporate food regime, we have to take account of those footprints that we're leaving behind. So all in all, it has to deal with looking at the technological advances and fixes that the food system and a food-based approach or a rights-based approach or humanistic approach, which goes into social justice, the equity and the access and all those things, that we are constantly aware of our footprint and how we need to go forth with that.
15 seconds. Thank you so much. Before Nathaniel Holmes goes, one thing, I want to actually to add to what Dr. Harvey said and tie Keisha Ray back into this, is because I see the synergism in another level, and that is the part, and Holmes, you actually talked about this, and our morals come from our motives. If we're motivated to do, then we can do some great things. And so our struggle is not that the technologies in there, that Lockman just said, we've been there at least 10 years, but do we have the motivation to do? Anti-Black racism creates a demotivation to do. So Holmes, Professor Holmes, as you talk about this, I hope you could chime in on that part. Yeah.
Certainly can. And before I get more specifically into that, I also want to just point out the fact how churches can develop networks, particularly in helping other churches in certain areas, particularly rural areas, because a lot of times it's just that kind of lack of support and structure, and actually maybe a place to congregate, maybe a place to kind of start out in terms of where the technology can be based, those types of things to provide access. There are already a lot of global partnerships for churches helping churches around the world, but I think that we can begin, particularly Black churches in this case, well, actually I want to say all churches can start to make those connections more closer to home, so to speak, particularly in rural areas. So, um, you know, to have that base where we can start to make that type of technology available. That's the first thing, kind of a practical sense. But in terms of the motivating factors, which Dr. Hodge, you just mentioned, starting to preach that every single day, every single week, that being embedded in people's moral and ethical and religious framework, and really exposing the type of racial practices as against God, so to speak, against something that's being sinful and unethical. If we can use kind of theological language, is very important. This is part of the reason why we got things like civil rights done and why slavery was abolished. It's only in kind of preaching these ethical factors do we motivate people to change. And so it's economics to be sure, it's structured to be sure. There's another question in the chat, I believe, in terms of how we can get the state more involved. Again, that's kind of organization starting with churches to help address these things, but to show people that this is the ethical thing to do because this is required in terms of divine justice. So I think all of those things are important to help us get to where we're trying to go.
Excellent, excellent observation. We can return to the chat, or we can, Dr. Ray, did you want to add to that?
I think about it just a little bit differently. So I'm looking at so when I was giving a webinar some years ago, there's a funny anecdote that happened. Dr. Patrick Smith, he gave a conversation about medical racism and Black people's health. Has this seminary background, right? And he said something about, he started talking about love, right? And it reminded me a little bit of what Dr. Holmes is talking about with hope, and thinking about the place of hope, the place of love in this conversation. And I think a lot of times it's natural for us to relate it to church, and it's natural for us to relate it to religion. From my perspective, though, I find that that's great for some people, but when you're trying to reach people who are not religious, or you're trying to reach people who are policy minded, who are data minded, and say, even if they can set aside their religious beliefs, because right now I'm in work mode and it means this, to talk about Medicaid and policy and health outcomes and social terms of health, I think choosing language that is rooted in I am human like you, right? Similar to the video that we watched, we talk about pain management. One of the issues there is Black people aren't seen as human like other people, why we get different pain management, why we're seen as we can withhold a lot more pain. It's one of the reasons why we have Black women dying during a of childbirth. Different pain levels, like different pain expectations. So I think when we frame language, again, that philosophy mind of me is that language matters so much in connecting and drawing people in. And I think churches are a great place to start this kind of relationship to, this goes against God's, we're made in God's image, against that. I think all of that is great, but I think we have to also frame it in ways that are not related to religion, and also frame it in ways of just humanity. Like, I am a person like you, I bleed like you. And for me, finding those ways to ground this, even if it means changing our view of justice, is a one way that we also have to approach this topic is how do we frame this in terms of justice? Like, it is unjust to do these things. It is unjust to leave people in pain. It is unjust to ignore our cries for help. And what can we root that injustice in? I think it is an approach that we're gonna have to really think about, that is not just about religion. Yes.
Yeah, I think that's an interesting observation. And I think that in part, that's an acknowledgement of the variability of audience, right? On the one hand, I think that there's something else though here, which is operating, which is the idea that one would be writing, as Toni Morris points out, she once did an interview where she talked about James Baldwin's admonition to her when he said, look, you're always writing with this little person on your shoulder, right? And the idea is, who would be that little person or that little institution on the shoulder of those writing this report? And what would be the tyranny, right, of that presumed audience? So that's in parentheses. Another piece is, if we were going to engage, right, indigenous modalities in the United States that broadly, for example, embraced notions of the divine, right? How do we incorporate those, right, in such a way, whether we're talking about Judeo-Christian or indigenous modalities having to do with ideas about the divine? And how do we incorporate those into a report that acknowledges that part of that in and of itself is what defines certain communities, right? So in essence, what one would be doing is arguing for these varied positionalities, arguing for a place for those positionalities at the table in amongst, for example, positivistic science. It would seem to me that we would be striving to do something like that, right? Which is no small thing, because the idea is that, you know, who would we be writing for? And I think that's the other piece. And whose bioethics would this be? We've already seen the Belmont report is a bioethics, to be clear, for institutions, for organizations, right? And a lot of the protective structures there are not so much there to protect people, but to protect institutions. But if we take a different position and see this as a people's bioethics, right, then it seems to me that it could change the framework.
We have 2 minutes. Okay.
Yeah. No, please.
So I love your question. I'll give my immediate answer, but I think this. If I were writing things or writing suggestions, input to other people who are writing these things, on my shoulder, I will try to have Mr. Charles Pollard, Mr. Freddie Lee Tyson, and others to this Tuskegee Report, and I want them to be watching me and even maybe inspiring me. I also want, and this is the way any indigenous community leader, not just Native Americans, would be thinking, to be thinking of our descendants, several generations, great-great-grandchildren, who are looking back at this report that we wrote and judging or being grateful for that. And then, so those are in the past and in the future. And then my brother David is always talking about our 13-year-old sister or brother or cousin who we don't know, we've never met, whose life may depend on who's alive today somewhere in Macon County or Africa or Native American community, whose future life may depend on what I write. So I've got ancestors, I've got descendants, and then I've got some young people whose future depends on what I write.
Thank you so much, Lachlan. Last words, T.S. Harvey, Keisha Ray, Kimberly Carr, Nathaniel Holmes.
Well, how do you sum this up? I would say this has been it's been a wonderful discussion that has been sort of transdisciplinary in terms of the perspective, and I think that the solutions have to at least be as complicated as the problem, right? So I think this is a very productive discussion, and I'm happy to have had an opportunity to participate.
Thank you. Dr. Ray?
Yeah, I'll just end on self-care. To keep doing this work, we have to take care of ourselves, especially when you're doing work on people that look like you. We have to read a lot of things that are not happy, that are not always sunny and bright. So resting, caring for ourselves, taking breaks so that we can keep up this good fight and keep doing this work is one that I will always, always preach. So take care of yourself.
Thank you. Thank you so much, Dr. Carr.
Yes, my thing is that as we talk about the Black bioethics and moving away from traditional bioethics, we need to continue to put the forefront of food. And when we were talking about the Native American indigenous populations, they're the ones who wrote the book on food sovereignty and what it means, and how they have their structures and their cyclical cycles of how they go through the seasons. So it's to bring in that cultural aspect. And one way to do that is through food. So I would hope that as we go forth, that those narratives and those narrative frames come into place. And maybe it can be a subset of what Black bioethics or indigenous bioethics looks like when it's all encompassing.
Thank you so much, my sister. My dear brother Nathaniel Holmes.
Yeah, so first I just want to thank you again for the opportunity of being here and just another affirmation of the humanity of all people and of course you know, activism and the reminder that everything that we're doing now, what we will do in the future, will not be in vain. It is possible to transform our predicament.
Thank you so much. As I close, let me first give the rundown for tomorrow. Thank you so much. So tomorrow, when we begin at 1 p.m., our brother Lachlan Foro will be our moderator as he talked through with Paul Wolpe and John Banger, both of them from Emory Center of Ethics, dealing with ethics and artificial intelligence, and an introduction to the debate. So I asked him to not be so technical that is difficult to understand, but at the same time make it challenging so that we can see where we need to go. And I'm telling you, these guys they've been emailing back and forth, and they're ready to go. So I'm excited about that. Then after that session, we will have I will be moderating between Dr. Prakash here at Tuskegee University, Dr. Brett Coppinger at Tuskegee University, and Gwen West, formerly of Tuskegee University, and Dr. West. They will be presenting on ethics, social media, artificial intelligence, and language bias. So finally, I just want to say my closing words. Those questions that we didn't get to because we looked at the most of them were AI related, and we will be dealing with that tomorrow. So we will represent your questions tomorrow. I also want to say, Joyce Question, thank you so much for your question, and we didn't miss you. We're going to represent that tomorrow as well. I just want to thank, first of all, the CDC, as I said before. I want to thank my brothers and sisters at Primer, and anyone who knows me for 10 minutes to know that my language is always about family, right? That's why Lachlan can't get away from me. I don't care how much he try to run and hide. He is my brother, and I love him. I want to thank God for Dr. Reuben Warren. He is like my uncle who actually made this possible. So all of you, my brothers and sisters, listen, we have such a challenge. I am so excited by how we started today. This was been amazing. It really touched me in many, many ways because it's giving us a roadmap. It's a continuation from last year. We're not with this dialogical with last year. We continue to build on something. We were supposed to have Craig Watkins from University of Texas. University of Texas. What's the name of that place down there? University of Texas, whatever that place, but down next to San Antonio. Can't remember. Anyway, Austin, University of Texas, Austin. But he has to present before Congress, so he will not be here. But we do have Dr. Prakash and Dr. Coppinger to step in, and they're going to do a really, really amazing thing. Because I think somebody mentioned today about ChatGPT. Oh my God, we have a conversation to have. So, assalamu alaikum, shalom, peace and blessings upon you. Remember, we are going to be, as Keisha may try to raise just now, we're going to be dialogical with the theists and the secularists to make sure we can grasp everybody and we all rise together. Take care of yourselves.